I'm going to go ahead and start the meeting. I started the recording. Welcome to the July. Give me a second as I let people in. Welcome to the July Optimizing Newborn Nutrition webinar. I'm stepping in for Kimberly. She's going to join the meeting a little late today, but welcome everyone. Just a quick update real quick. We will be sending out the second quarterly reports next week. We will upload it into Teams and then also send it out to the data leads. Now I am going to pass it on to Claire if you want to do introductions and then start us off with the webinar. Claire, you're still on mute.
Sorry so much. Thank you, Linda. I wanted to check with Dr. Patel if you had anything to add before we get going.
I did want to add just one thing about the next audits. We are going to have some questions. I'm not sure if we'll make it into the next audit or the August audit, but we do want to learn from the centers about changes you've been making. And so there you will see some new questions in the audits about describing any changes you've made as part of this initiative in policies, care practices, things that you've done in terms of testing. We'd love to kind of hear from you as we begin to focus more about kind of changes related to the drivers related to the aims of this initiative and the smart aims that you have. So I did want to just mention that to expect that in upcoming audit.
Thank you, Dr. Patel. Hi, everyone. I'm Claire Eden. I'm a lactation consultant, and I direct the breastfeeding programming out of the Georgia chapter of the American Academy of Pediatrics. And I know you've all seen a lot of my face already, so I'm very happy to introduce our faculty for today's webinar. Our topic is standardizing supplementation for breastfeeding success. This is sort of a part 2 of what we started last month. And our faculty today is Dr. Marche Smith and Dr. Taryn Fairley. Dr. Marche Smith is a board-certified pediatrician, and she serves as an assistant professor of pediatrics at Morehouse School of Medicine here in Atlanta. She works clinically. I don't know how you do this, Dr. Smith, but she works clinically in both general pediatric, inpatient, and outpatient settings at Children's Healthcare of Atlanta at Q Spalding, and then also as a newborn hospitalist at Emory Decatur Hospital, which of course is a participant in the Optimizing Newborn Nutrition Initiative. Dr. Smith is also an IBCLC, a board certified lactation consultant, and she has special interest in community engagement, childhood obesity prevention, and breastfeeding among minoritized populations. So welcome, Dr. Smith. And she will be co-presenting today with Dr. Taryn Fairley, who practices general pediatrics and breastfeeding medicine at Kaiser Permanente, also here in the metro area. She's a member of the Academy of Breastfeeding Medicine and adjunct faculty at the Emory School of Medicine. She currently serves as a physician chair of the EPIC Breastfeeding Committee here at the Georgia chapter of the American Academy of Pediatrics, and is also our chapter breastfeeding coordinator, and of course advises the GaPQC ONN initiative as a subject matter expert. So welcome, Dr. Fairley and Dr. Smith.
Thanks so much for those introductions. All right, Dr. Fairley, you ready for me to just jump right in? All right. So thanks for having us today. Really excited about today's talk as I am on newborn nursery this week. So I've actually run into all of the things that we're going to talk about this morning. So our focus today is supplementation, as we've mentioned. So we really want to talk about standardizing supplementation. And remember, this is for our term nursery babies who are healthy, otherwise with no other things going on. We will talk about jaundice and hypoglycemia separately because we know those are common things that we run into when we're talking about supplementation, but for all intents and purposes, we're leaving that out of today's talk. But we are going to, again, talk about safe feeding, the role of supplementation and how to do so. And again, these are for our term healthy infants who are not high risk for jaundice, and who do not have severe and or persistent hypoglycemia. Next slide. So among the millions of things that we talk about with parents, what do we exactly want them to know about feeding, right? So we talk to them about breastfeeding, and we come to an understanding that parents need to be taught and need to learn about breastfeeding. But when it comes to introducing bottles, we don't really have the same emphasis. And when we're talking about supplementation, we know a lot of times that is using bottles as one mode or one method of delivery of whatever type of milk that is being given to the baby. So in considering that, whether it be bottle feeding with formula, being express breast milk from the parent, or being a combination of two, which is the combination feeding. And that combination feeding, remember, can be any of the things that I just mentioned. Also with the use of a lactation aid that might also be useful depending on what's going on. Use of donor milk. And any most importantly, are the direct breastfeeding, which we're assuming we're putting into the mix as well, and that can be, of course, breastfeeding or chest feeding. We just need to consider that it's not always as easy as just saying this baby is being strictly breastfed or this baby is being bottle fed. It could be a combination of the two, and that it's a dynamic process that has to be constantly reevaluated to meet the needs of whatever the baby is needing at that time. So we need to help parents understand that they have choices in feeding their baby, but we want to, again, make sure that we're doing it to the best of our ability on the parents' end as well as on our ends as healthcare providers as we're taking care of these babies, and then to support them in the choice that they make. Next. So in considering feeding methods, we need to also make sure that we're doing so safely. And so there can be a lot of nuances that we sometimes overlook or sometimes assume that a lot of parents and healthcare providers alike already know about feeding, right? So some of those things that we need to consider, whether that's direct breastfeeding or adding in our supplementation and other forms of milk delivery, that sanitary storage and preparation is very important. Again, no matter the milk or the milk substitute potentially, and that, remember, includes our hand washing, having clean surfaces as well as clean containers, and then the proper thawing as well as warming of any milk products, and then remembering that proper reconstitution of infant formula in concentrates or powders is also something to talk about with our families while they're here in the hospital, as well as in preparation for getting them home to continue the practices that we've kind of worked with them while they're on in the hospital with us. And then remember, for all babies, we want to see, are they actually ready? So what does readiness look like? So teaching families to know, okay, when should my baby, or when does it look like my baby is actually ready to participate in feeding, and looking at a lot of those cues that sometimes parents can overlook or not quite understand or know when to start a feeding. Positional stability is also very important, especially when we're trying to get babies to latch properly so that they're able to latch efficiently and then have that coordination between their suck, swallow, and breathe patterns to be able to do, again, safe feeding for no matter the method of delivery, but in this case, we're talking about the direct breastfeeding aspect. And then lastly, their responsiveness. So how to tell that a baby is eating comfortably and being satisfied with the meal, and when the baby's done eating, right? Because that can sometimes be a challenge to see, is the baby actually satisfied? Is satiation, taking place, or do we need to be doing something to help the baby be a little bit more full at the conclusion of the feeding? So all of these things working together are going to constitute our safe feeding that we can help give parents a little bit more comfort with. So in order to make all of this come together with some of the things that we're going to talk about in a second, case studies are also usually, or always, in my opinion, very helpful, because then you can piece information with an actual patient. So our virtual patient today is going to be Miss Little Frederica. And so she was born overnight to first-time parents Theo and Jessica, who are very excited. She weighed 3 kilos and was born via C-section after failure to progress. She was placed skin to skin in the OR shortly after delivery, but didn't latch to breastfeed until earlier today, and we are seeing her for the first time. But now, the good thing is that now she doesn't seem to want to unlatch, so we're latching well thus far, even though we got to kind of a rocky start. So in order to have a better idea of what to anticipate, we need to make sure that everyone understands what normal newborn behavior looks like, because it can be a little different than your older kids. And sometimes because it's so new, we can potentially think that things are a problem when in actuality, it actually may not be. So we think about our primitive days. We can think of all babies being cave babies, if we want to use that terminology. And in order to survive the cold and the big saber-toothed tiger, which sometimes some of us on the medical team can be the big saber-toothed tiger, we want to make sure that we understand what is normal, right? So babies have newborn reflexes that serve very important purposes to help cue us that they want to be held and or they want to be fed, okay? However, these reflexes can be blunted by quite a few things, and that can interrupt the baby's natural physiologic feeding from actually taking place optimally, right? And some of those things can be a combination of traumatic or long births, surgical births, so your C-sections, maternal medications we know can also play a part in the baby's alertness or interest in feeding, fluids that were potentially given during the birthing and laboring process, swaddling, which we know we love to swaddle the babies, but sometimes it can interrupt, and then pacifier introduction. And again, we're not pointing fingers for any of these potentially being the culprit necessarily, but we know there are medical indications for all of those things being useful, but this is just an observation that we know that they can potentially have some potential negative consequences or interruptions, we'll say, with the optimal feeding for the newborns, because we know there are a lot of things taking place all at once. So in order to mitigate some of these things, and to not interfere with the establishment of lactation any more than we actually want to, then we want to promote, when able, our golden hour, so that hour after birth, trying to get the baby to latch, which unfortunately Frederica wasn't able to do successfully. It's okay, we have some time. Optimizing our skin care, which they were able to do with her, and which we hopefully you all are doing at your hospitals and facilities, and then using our responsive feeding, which we'll go into in a second. So when babies have their sucking needs met at the breast, it does send that communication to the body that, hey, we want some milk. And so it's essentially like the baby calling in the orders. We know today is Amazon Prime Day, so they're putting in their Amazon Prime order for that milk. So let's see what's kind of going to happen next. So as they're putting in their order or their demand, we know that that's going to help with our supply, right? So if you want to actually think about it, birth kind of interrupts that concierge service that they're used to getting from the placenta. So they're used to getting that 24/7 delivery to them with no effort on their part. And now they're coming out having to do a lot of the ordering on their own, right? So instead of their parents or significant other, someone else ordering their Amazon orders, they're having to get up, get their credit card, and put in the order for themselves, right? And that can be a huge transition for them, can be a bit of a challenge, and most importantly, it's a lot of work for them. We do also see with hypoglycemia and some feeding challenges postpartum that there can be some suck, swallow, breathe challenges that you might also see. And so it can be kind of stressful for the baby. So we also want to be aware of that as well. But they're still hardwired to actually do this and to do this well, to thrive and to feed, even though sometimes they may want to latch more so for comfort than nutrition, but again, both of the latching purposes are still very important. All right, so over time, this is taught our physiology. Has taught us that these feeding cues and those frequent feeding cues are very important to make those physiologic shifts, okay? And so those shifts ultimately result in lots of latching and hopefully lots of feeding. We know that while lactogenesis 2 is going to happen regardless once that placenta is delivered, that the volume of milk that is available is going to be greater when the infants are sucking more frequently after delivery, again, putting in those orders. and that the volume of colostrum available to neonates during those first couple of days of life are going to be quite small relative to what's going to happen after that lactogenesis 2 begins. And so if we think about Frederica, she had a bit of an early start on her birthday, right? So tough little transition, but she's now sucking, so her heart is content, and she's going along with that physiologic transition that we're anticipating, with the goal of hopefully, which we'll see in a second, not leading to the opposite end of getting overfed. Okay, so again, back to our physiology. So we know that the small quantities of colostrum are going to be a little bit different than the volumes that you would think about later on as the baby continues to grow. But those small quantities are going to be appropriate for the size of the newborn stomach, which is something that we always try and remind parents of. I even wear like a little ball on my badge to give them something visual to see how small the baby's stomach is, which I think really connects with them. It's also going to hopefully prevent hypoglycemia, again, in healthy term infants who we're talking about for today's talk. Also be appropriate for the gestational age, as well as it's going to be easy, hopefully, as they continue to coordinate that suck, swallow, breathe reflex as they're simultaneously trying to feed. Okay, we also have to recognize that term infants who are healthy also have sufficient body water, excuse me, to meet their metabolic needs, even if it were to be in a hot climate. We know basically around the world right now, everybody seems to be in a hot climate with the weather. And so the fluid that's necessary to replace any type of insensible losses that they may be having is going to be adequately managed by breast milk alone. We don't need anything extra, but we also anticipate that they're going to lose some weight because of that physiologic diuresis that's going to happen with the extracellular fluid during that transition from intrauterine to extrauterine life, as well as the passage of meconium as well. So we try and make sure parents also understand that, and that we know that these are natural things that are going to be happening. And so we're going to be monitoring all of that in addition to making sure that they're feeding well. All right, so back to our friend, Miss Frederica. So mom and dad, who are Jessica and Theo, remember, they're wondering wondering what all this breastfeeding means, right? They're getting bombarded with a lot of information, so they're just trying to make sure they're doing what is great for their baby. So right now she's taking some breaks, but she starts to cueing again, which indicates for them, hey, maybe she wants some more. They took a breastfeeding class before delivery, so they recognized that when she was putting her hands in her mouth, smacking, and doing all of these things, that they were feeding cues, which is good, and that's important. Whenever they try to take her off the breast, though, she fusses and begins to cry, so they're starting to wonder, what's going on? Does that mean that she's actually not getting anything? Which is a very common question that parents are going to ask. So Theo's mother, so grandma, she's in the room visiting, and she says, well, maybe you should just go ahead and top her off with some formula so she'll settle, and then you all can get some rest. And I know that we commonly hear that a lot, right? And so she asked the nurse to just go ahead and bring her the supplies. She'll show them how to do it so that Theo can get some rest and he can know how to bottle feed the baby. And then Jessica can subsequently get some rest as well. So grandma proceeds to put the nipple of the 2-ounce ready-to-feed bottle, which we'll talk about volumes in a second, into the baby's mouth. Despite her having spent some time at the breast before this, right, in the past couple of hours with the constant feeding, she begins to gulp the milk, right? And so grandma says, see, we fixed her, right? She was starving. And so is that actually what was happening is the question. Next slide. All right, so was she actually starving, right? So again, if we're thinking about our weight loss post-birth, we know that, again, losing weight is going to be normal, right? So the question is, do we know what her weight is right now? Maybe, maybe not. And so there was a study done in 2018 that looked at weight gain during the first week of life being a predictor for weight or being overweight at the age of 2. And this was a prospective cohort study done in 2018 again. And so as things are changing and these metabolic adaptations are happening, we're trying to see kind of what consequences are happening and what role are we potentially playing in that, right? So we know that babies need to be hungry, right? We don't want them starving, but they actually need to be hungry. That's one of their primitive things, right? And so in order to make adequate metabolic adjustments, that's what kind of drives that. And then in order to be able to learn how to eat well, and then ultimately to be able to create a full supply. Remember, they're putting that order in, that supply and that demand dynamic. Again, we're not starving them, and so we wanted to see, okay, do we have an objective way to help us see that we're actually not starving the baby, right? And that's when our new tool comes to the rescue, which is something that we love, and I'm sure you've heard about multiple times at this point. And so around 24 hours of life, this nomogram is very helpful in creating a risk stratification to see, based upon what my baby's weight loss is, should I be concerned? Are things going well? Or do I need to potentially go ahead and proceed with supplementation? And so back into thinking about preventing obesity, we know also from a different study in 2020 that the prevalence of obesity among children less than the age of 2 is on the rise, which I'm sure all of you are also seeing in your everyday lives, as well as if you are work with children, seeing that clinically. And so we know that metabolism is programmed in infancy, right? So that's something that I think a lot of people don't necessarily understand or recognize, especially a lot of our parents. So having that conversation as you're doing a lot of these early introductions and establishing feeding patterns and practices is very helpful intuitively to get them also on board with understanding how important it is to help set these things up early on. Because we do see that overnutrition of newborns in the first few days of life is associated with future risk of being overweight, as well as leading to obesity, which this study from 2020 showed that after adjusting for birth weight, that infants who were overfed 5 of the first 7 feedings were 5 times as likely to be overweight or obese at their 4th year well visit or checkup. And so that's some data that's, a little bit striking to think about how early, in the first few days that you potentially are setting your child or your family up to establish healthy feeding practices and protocols that can potentially affect them for many years to come. And so let's go back to our baby. So is she starving? In order to actually answer that question, we have to also consider what happens when a baby takes a bottle, right? So when you're putting the bottle into the baby's mouth, how much of that is voluntary from the baby's end versus involuntary, okay? And so in the early days of life, they can easily be overfed because as they're sucking, that need is just so great, and the bottle is readily available, full of milk, unlike the breast milk, right? Because we're still trying to establish our supply, that milk comes out so easy for them. And that's a question that a lot of families ask me is, okay, well, why when I offer the baby the bottle, does she seem to drink it so well, but when I put the baby back on the breast, she doesn't seem to be as interested, right? So that's hard work when you're putting the baby on the breast or having to use a lot more muscles versus when I put that bottle in there, they're relaxing at the beach is essentially what's happening. So they're not having to put in as much effort as they do because everything is already there and it comes out so quickly. And so in considering that, we have to think about also the flow rate, right? So how quickly is that milk actually coming out of the nipple? And are we also using pacing to help slow that and to help it be a little bit closer to what is going to happen at the breast, so that we can prevent that disinterest or that disengagement from happening when we're potentially going back and forth from the breast and the bottle if we need to, okay? And so sometimes parents and other members of the care team can misinterpret that as them being really hungry or not getting enough at the breast when they're so vigorous when you're giving them the nipple. But remember, as they're guzzling and gulping all of that down, that actually isn't going to be ideally what you want to happen because it's coming so quickly. And Dr. Fairley likes to akin this to frat party funneling. So everything is just, they're having a good time, right? But it's just actually just coming out, or trying to potentially like stick your mouth on a water hose, right? That is coming out quickly. And sometimes you can actually cause more harm than good because of how quickly the flow rate is, and something that you need to consider. Those behaviors can also that look like interest can actually be signs of stress. So when the eyes are wide open because they're basically trying to keep everything up, that gulping or that rapid swallow that we mentioned, as well as some leakage. So sometimes it can be coming out so quickly that it starts to leak around the sides of the lips. And then some babies will even start to cough because the milk is coming out so quickly, which we know can ultimately lead to aspiration, which we do not want. So feeding should be effort dependent, so isocaloric, and we want it to be voluntary in these reliable infants who are still learning, still trying to, again, do that suck, swallow, breathe reflex. And there are many ways that we can help families do this safely, okay? And so thinking about volumes, this is very important and hopefully something that you all at your facilities and hospitals have considered if you already have a supplementation guideline. Thinking about what volume should I anticipate based upon the age of my term healthy newborn, okay? We know that they're going to be hungry. We do not want to starve them, but we also want to make sure that we are giving them volumes that are appropriate for their gestational age, for their size, so that we are not potentially supplementing when we don't need to if they're otherwise meeting their goals. And so this just is a very good table to reference, and this is from the Academy of Breastfeeding Medicine under protocol number 3, to just talk about, or to just show you rather, some typical volumes. This is also helpful if you wanted to talk about this with your family so they can kind of anticipate what they should be looking for with their children during the first couple of days of life, and as well as what they can anticipate when they're going home until they're able to follow up with their pediatrician. All right, let's go back to our baby. So during that feeding, grandma decided to give her 45 milliliters when she was not even 24 hours old yet. So based upon the chart that we just saw, do we think that was a little bit too much for her? Just right? Not enough? It was a lot, right? All right, so if we look at our next slide, this essentially just says a summary of why we don't routinely supplement everyone, right? So if we think about other things that we just talked about, we're trying to prevent that feeding intolerance, right? We're trying to make this as physiologic as possible without interrupting the breastfeeding relationship if we don't need to, if there's no medical indication to do so, because we're trying to as well encourage that responsive feeding as well as responsive parenting, so that they're looking at all of the feeding cues, looking to see if satiety is taking place, recognize when the baby could potentially be crying because of something else as opposed to still being hungry, as well as knowing when the baby potentially may want to be sucking for nutrition versus sucking for comfort. Again, because we're trying to ultimately optimize our breastfeeding relationship for the mother-baby dyad. And then ultimately, we know that long-term, this is also going to help prevent obesity as they continue to grow in age. Okay. So in summary, for our feeding goals, we want to teach the infant to feed, right? Because we know that this is completely new for them. So we're trying to give them some grace, but also, guide them along the way. We're also trying to help with our metabolic transitions and to not overfeed, because we see the potential consequences of that. And then remember, we want to do everything safely. So we want to use those slow flow nipples if we are using a bottle for any type of feeding, or those preemie nipples, just to kind of mimic the flow that the baby is going to get at the breast, just to make it a bit easier as they're continuing to make this big transition. We're also optimizing our skin to skin, not doing any co-sleeping in order to stay safe, and then making sure that we're feeding often enough, again, based on those cues to make it as physiologic as possible. All right, back to our baby. So after grandma decided to give her 45 milliliters in a whopping 10 minutes, she seems to be happy until she nearly spit all of it up, right? So that's another common scenario that we see parents or potentially healthcare providers as well will give the baby this large volume. You lay the baby down after hopefully getting a good burp, but then the baby spits it all up, right? Because we have to think about how small is their stomach, even though they seem to be wanting to drink more. So grandma left. Mom and dad were a bit nervous to try feeding again because they didn't want to make the baby spit up again. So they called the nurse, who reassured them and offered to let them sleep a bit to recover. They fell asleep, and then, of course, parents are already sleep deprived at this point. So they woke up a whopping 6 hours later to a screaming Frederica, who latched briefly and then she fell asleep, right? So the next 10 hours or so, mom and dad woke her up every 3 to 4 hours based on the nursing instructions that were left on the whiteboard. And by the time she was at 37 hours of life, her weight had dropped by 8% from her birth weight. So what do we do now? So based on her being down 8%, do we automatically need to supplement, or do we have some room, right? So what are our next steps? So if you could, in the chat, could you vote on whether or not we should supplement? So you can just say yes or no. Yes would be assume yes, we need to supplement. No would be no, we do not. And let's see kind of what we think. And I have Claire and Dr. Fearley checking out the chat for me as well. So I see a lot of no's.
Yeah.
I'll give it a couple more seconds. Okay, it looks like we're having all no's. No brave yeses.
There's no brave yeses in the chat at all. No. Anybody else? Last round, I feel like we should have some Jeopardy music.
Right?
Right. It could be kind of fun.
All right, well, let's see.
All right.
All right, so this is our lovely Newt tool. This is our Newt graph that we use for her. And so based on us plotting all of her information, which you can see the birth details here is where we put her weight, her date of birth, as well as what time she was delivered. After that, we see that it was a C-section, as mentioned, and that she's being exclusively breastfed. And then we put in her 37-hour weight under that, and we see the calculation that she is down almost 8%. And so at that, we see that she is between the green line, which is our 50th percentile line, and then our yellow line, which is what she's closer to, which is our 75th percentile line, right? Okay. And so a lot of institutions, both inpatient and outpatient, because I'm one of those people that was trained with, okay, if it's more than 7%, we automatically need to do something because that's abnormal for everybody under all circumstances. But what Newt has taught us is that there actually are a lot more questions that need to be asked and some more data that needs to be considered before assuming that a percentile ultimately guides the decision that needs to be made, and that decision has to be made for every single baby in the same way, right? Because that's not true. And so what happens here, what happened with our baby Frederica, is that her feeding intolerance led to parents delaying that feeding, so she had a longer stretch of not actually feeding. She had her spitting up, and then she ultimately got behind, right? So we're trying to play catch up. You notice that there also wasn't a weight that was taken until she was 37 hours old, right? Which is potentially problematic in her case because this shows us that we potentially could have intervened a lot sooner if we saw that she was starting to trend downwards toward that 75th percentile, which is when we need to ask some questions, okay? Let's see. Also, if we think about in the other webinars, remember our 75th percentile means we need to slow down. Yellow means slow down, right? So that we can actually ask some questions to see if this infant is at risk for further weight loss, and if we need to just go ahead and proceed with supplementation while we're subsequently also screening for other risk factors that could help us figure out why she has lost this weight within this time frame. So in order to prevent further issues, right, we still want to use our Newt tool as much as we need to, but we need to also provide education, right? We need to make sure parents understand what is normal for their baby. So what is normal weight loss? So sometimes I will even take, well, a lot of times I'll take this new calculator on my phone while I'm in the room with the parents and actually show them on the graph where their baby falls to give them an objective way of actually seeing whether or not what we're doing is working, or to give them reassurance that actually what they're doing is working for their baby. So we still want to feed the baby, even in Frederica's case where she was spitting up, and not let her go for 6 hours between feeds for fear that she's going to continue to spit up, because we're trying to keep her engaged in feeding, which is another reason that we like to do rooming in, hopefully at the hospitals that you are at as well, in order to keep that breastfeeding relationship dynamic and ongoing, and to prevent that late feeding issue or any interruptions that potentially are because of us on the medical team. Okay, and so you want to weigh your baby consistently, or in this case, we use the Newt tool every 12 hours to reassess to see if what we're doing is actually working or if we need to be giving additional interventions. And then the rooming in, again, is very important to making sure that we're meeting all the needs and not potentially being the reason that the baby is missing out on opportunities to feed successfully. All right, and so there are some early indicators that can be used if you are using standardization, especially as you all are coming up with your own protocols at your institutions. So something that you want to consider is that if the weight loss is greater than the 50th percentile, if parents are reporting painful feedings, if baby has poor urine output or stool outputs as you're checking out their 24 outputs, or if the baby is fatiguing or having lethargy with feedings, those are automatically things that you need to stop and think and intervene with, so that you can potentially prevent things from continuing to go in the wrong direction. And so that would automatically, if we're using this as a guide, constitute for an IBCLC consult, so that we can troubleshoot and actually see, is it an issue with milk transfer? Is it an issue with milk supply? Are there potentially some things that we can do to help with that? And then moving the milk that is there, right? So hand expression is wonderful, especially in the first couple of days, and a lot of moms feel like they're actually able to express a lot more milk, and the comfort of it is a little bit different than using a pump, but a pump is also an option. So hand expression or pumping to actually move the milk from the breast, in addition to, of course, having the baby latch if able. To continue nursing, right? So to continue to get that goal of 8 to 12 feeds in a 24-hour period. And then typically proceeding with supplementation if weight loss is greater than that 75th percentile, as you're again controlling for all of these other factors that may be contributing to that weight loss. But again, not assuming that that 7% automatically means you need to supplement, but actually looking at your Newt and seeing it, are we at the 75th percentile to where we need to go ahead and intervene with some supplementation. And so this next slide is an example of an algorithm that is used at Oregon Health and Science University, and this is based upon the ABM protocol as well. You don't have to necessarily go through all the details on here, but as you can see, they're determining the infant's weight loss at the top center diamond based upon the Newt that we just went through, and then automatically they go down their little tree where if we're at the greater than the 75th percentile, or there are medical indications for also proceeding with supplementation, then they're proceeding to do, of course, their feeding assessment, which is the most important thing to do. Okay, and then they're also looking at mom's history, as well as looking at the neonate itself, making sure the physical exam doesn't show any anatomical things such as lip ties. Of course, hopefully all of those things would have been seen on the initial exam, but just to look again, because sometimes they can be missed and not necessarily be problematic. But then going ahead to proceed with supplementation if necessary. And then again, some other details here, which I believe Dr. Fairley just placed into the chat if you all actually want to look at the link that shows you this algorithm more in detail, just so you can kind of see how this might be useful at your institutions if you desire to include some of these things. All right. So next slide, we're thinking about safety, right? So safety is important no matter what we're doing, supplementation or not. And so this is just a reminder that this does not include our babies who have jaundice, who have hypoglycemia, or who are in the NICU, because that gives us a whole different scenario to where we need to consider a lot more things. Again, Newt is going to be your best friend, whether you're considering intervening with your baby, or if your baby, for instance, just has 2% weight loss, you still should plot it out just to see where the baby falls on the Newt, just to make sure nothing is being missed. Because as you can see, if we were thinking about the 75th percentile in a baby who was born via C-section who lost 8% versus a baby who was born vaginal delivery, the percent weight loss is going to be a little different, right? And then when we proceed to the 90th percentile for weight loss, an 8% versus an 8.5% weight loss is also different based upon the method of delivery. But again, that's still at 37 hours of life. So a 90th percentile is completely different from a 75th percentile when we're looking at weight loss, even if we're controlling for other factors. it needs to be plugged into your NUT because your interventions are going to be different. And so that's why it's so important to actually put that information in, to graph it out to see what needs to be done for your baby, so that we are making sure that we're keeping safety at the forefront for all that we're doing.
I will say, Marcia, Dr. Smith, this is something that I think once you get in and start using NUT much more routinely, you realize how often a lot of us, in the effort to be breastfeeding friendly, are not supplementing children early enough for safety purposes. And for staff who may be more reticent to impose supplementation guidelines or set up a care plan or do anything else to kind of micromanage supplementation, as somebody once said, you're micromanaging what we do on the floor. Sometimes you just give them formula. But for folks who are resisting that standardization, I think this is often quite comforting. There's actually quite a bit of medical indication on the floor that I don't know that goes recognized. And NUT makes it pretty plain.
I agree. All right, so then when we think about replacement versus supplementation, there are some things to consider, right? So if the parent has any breast or glandular hypoplasia, then we know that that's going to ultimately determine or help drive how much of a supply that they might be able to make. So that might be an instance where you actually might want to do some replacement feeds. And that means that you're giving full volume feeds, of course, after you're offering the breastfeeding first, and you're doing that for each feeding, right? In order to make sure that the baby is not getting behind. Another instance might be when that baby has lost more than the 90th percentile for weight loss. Based on what you were able to gather from the NUT. Full feeding replacement is going to be what you're going to go to for that baby. While supplementation might be a better choice if you're at that 75th percentile for your weight loss, and or if you're having pain with latching that is not responsive to the interventions that have been tried thus far. Some moms also have really sensitive nipples, so sometimes that can also interfere with being able to get some sustained feeding. And so that's when you're giving half or less of the full volume, again, after you're offering the breastfeeding first, to give them a little time to make those transitions on both ends. And of course, remember, you're reassessing, replotting the baby out on the NUT to see if additional interventions need to be made, or to see if you can kind of ease up with some of the replacement or supplementation if the baby starts moving in the desired direction based on hopefully not having further weight loss. And so the choice of supplement is also something to consider, right? So based upon our HWO guidance, we know that direct breastfeeding is going to be our go-to. That is our ultimate goal for all families who desire to exclusively breastfeed. And so when direct breastfeeding alone is not enough, we know that we have a next option, which is going to be as optimal, hopefully, because we're going to offer parents express breast milk, right? And that can be done via hand expression and or pumping or combination, doesn't matter. That's going to be the next best thing after offering the breast, of course, when able to. If that is not enough based upon supplementation needs for the baby, then donor milk is going to be the next thing in line that you want to consider using, again, after you've offered direct breastfeeding and the express breast milk when able. If your institution has donor milk, hopefully it does. That's a great option for families. And sometimes it helps parents build their confidence also in the meantime as they're working on building up their supply, as well as getting more sustained latched as well, to kind of bridge them over, to give them that added reassurance that the baby is getting what they need from a caloric standpoint. And then lastly, formula is going to be our last option as we go down our list. And so we do see that when available, your protein hydroxylate formulas can be a bit more preferred as opposed to your standard infant formula, in order to avoid exposure to intact cow's milk proteins when able. But of course, it's not the end of the world if you don't have that available at your institution. Some studies show that it also reduces bilirubin levels a little bit more rapidly. But again, we are talking about term healthy babies, so not necessarily the ones who were concerned about jaundice, but just something to consider if you have it available in your institutions. And also remembering that supplementation with glucose water or anything else that is not express breast milk, donor milk, or formula is not going to be appropriate for your baby, and something that you do not want to do. And so when we think about donor milk, we know that there is some evidence that use of donor milk in NICUs improves lactation outcomes. But again, that's just something to consider, though we're talking about term healthy babies here. We know that it's also the biologic standard for infants, which is the closest thing that you can get from the parent's own expressed milk. And then it helps with their microbiome development as well as antigen exposure, which we know has long-term benefits with them as they continue to grow and develop. And so back to our volumes, we know that this can be a slippery slope for a lot of us, as we know there's not a lot of data that truly has a clear-cut algorithm necessarily for helping us, but we know that there are studies that give us a general idea and that we do have some support, like the ABM protocol that I showed you a couple of minutes ago. We know that formula-fed babies are going to get more volumes like Frederica did when she took the 45 milliliters. There's more volume that's readily available. They're able to get it out of the nipple a lot quicker than they are at the breast because it's not taking as much effort on their end. So that's something that you also want to consider so that we're not potentially doing more harm than we are with benefits. The supplementation, again, should mimic what is typically going to be available in the colostrum in terms of volumes, in terms of the age of the patient and the size of the infant. So remember the chart, which again shows you your volume expectations for each day of life as a general rule of thumb to help guide you. And then we know that more important than the volume, the flow is very important. The pacing of the feeds, again, trying to get them as close to mimicking what's going to happen at the breast to help to not allow them to guzzle so much of a volume so quickly. Like our Frederica took the 45 mils in 10 minutes. We know that was a lot. And then, of course, direct breastfeeding beforehand, because we're trying to optimize milk production from parent, as well as to not cause interruptions in establishing that milk supply, if at all possible, while we're also doing the supplementations from a medical standpoint. And remember, it is a medical intervention. Sometimes we can forget that supplementation is. And so we have some options for actually methodology with providing our supplemental feedings. A lot of facilities, I know we do here, Emory Decatur, have little supplementation kits that actually have all of these things in a little bag for the families, as well as some literature to provide them with for education. We know that we can feed the baby with a cup. We can do a little finger with a glove finger. We can also use a syringe and do all those things actually at the chest or at the breast. They all help limit the flow, again, so that it's not coming out so quickly. They also simultaneously are controlling the volume as you're kind of setting that up for the baby to begin with at the beginning of the feed based on what you're giving them at a time. There is little data regarding the breast chest feeding outcomes and the use of this, but from a clinical standpoint, we know that it is helpful also to continue to help with emotional bonding with the families, as well as just continuing to promote them getting to know each other and to establish the feeding relationship. The pace feeding with appropriate slow flow nipple, so that preemie or that zero nipple can be used. It is preferred though with your larger volumes and or after 48 hours of life. Just because, again, the infant's going to be, of course, maturing a little bit better. And then, of course, your volumes are going to be a little bit different than what you would be giving on day 0 or day 1 of life. So where those smaller volumes may be more beneficial to be giving with the other methods that have been mentioned. So if we go back to our baby, Miss Frederica, mom and dad started supplementing with the syringe after the feeds that were being offered at the breast with 10 milliliters. They then worked with her nurse on bottling slowly, so doing that pace feeding with the green slow flow nipple being upright with good pacing being demonstrated. Lactation also saw mom and dad and helped them with doing some hand expressions so that she could use more of her colostrum that was readily available, and to also help promote her supply. And then at discharge, based on her NEWT, it was still greater than the 50th percentile, so still between the green and the yellow line, but it was less than the 75th percentile, which was that yellow line that we showed you. So still making some improvements in comparison to what we started off with 37 hours of life. And then her breastfeeding sessions were also lasting longer, so she was able to sustain her feeds a lot better. And then mom was noticing that she was starting to also have some breast changes and was feeling more confident about the feeding overall. And then lastly, most importantly, they had follow-up with their pediatrician the following day in order to check in to make sure that things were still going well. So some of our take-home points that we hope that you gather from this are at least half of the supplementation that we're doing, there is no medical indication for. And then we want to think about objectively, is there a reason that we should be potentially supplementing, right? That's where your NUT comes into play. That's where of course, your medical team is going to come into play, specifically your medical provider, so that they can ask more questions to be able to get a better assessment, as well as your lactation consultant coming in, doing an assessment to see what needs to be done. There's also a systematic approach to supplementation that we hope that you have been able to see to provide supplementation safely, as well as to provide some type of consistency for the feeding education that's being given, because a lot of patients and families are seeing multiple people throughout the day, and sometimes the information can be different, right? And so when you get in the room, the story and the plan could be completely different than what you potentially had discussed the previous day. So it's always important to make sure everybody's on the same page, so that the goals are going to be the same, and ultimately so that the patient and the baby in this case gets what they need to continue to thrive. And so optimizing feeding in the hospital may impact lactation outcomes, which we know, and which hopefully you all are continuing to follow with your projects and your protocols. BMI percentiles, as well as childhood obesity in the long run, which is where we're trying to combat, hopefully, with being able to optimize our feeding during the early days of life in order to set our families up for healthy lives going forward. Thank you so much for your time, and I'm going to pass it on to Dr. Fairley as well as Claire.
Yeah, I think we had an interesting comment in the chat about using alternative feeding methods longer. Dr. Smith, I don't know about you, but I certainly have lots of people who come in syringe feeding on day 7 to 10, and it's often an issue. And so while you can, and people do, and I think the education provided is probably great and exactly what should be done, but that retention for tired people trying to feed a brand new cranky little person, I'm not sure that the retention is there in the way that we need it. And bottling is an unfortunate reality for a lot of our families. I'm in private practice, mostly 30% Medicaid, so a lot of my parents are working, all of my parents are working families, right, in general. And a lot of mine are back to work at 6 to 8 weeks, and bottles are a part of that reality. So I feel like the hospital course is a chance to discuss bottling and in some ways that we may not get again, including for formula feeding only families. I could go off for a long time about how paced feeding is for all babies. So Marcia, do you have anything else to add?
No, I definitely agree. Since I do outpatient also, I see all the things that you mentioned when I see them for follow-up. And so I think if we can help give this education while they're still in the hospital, like you said, they're getting a lot of information, but it still gives an introduction so that it's something that can be continued in a conversation that can be continued when they're being seen for follow-up.
And I feel like sometimes syringe feeding, some of these other things are quite outside of the cultural norm. And so that, they go home and they kind of build off the education that we give them. But, you've got grandmas who's there with the boss. We have to get our piece in. Any other questions or comments?
Feel free to reach out you can respond to the email that Kimberly will send out. I know Linda has some wrap-ups, but you can get a hold of us easily. I'll put contact info in the chat, or Dr. Smith and Dr. Fairley, if you want to throw your contact information in the chat. I'm going to hit the link again for the guideline flow sheet that was shown in the slides. I want to let y'all know that we've got some new micro lessons up on Train, the alternate feeding methods, and pace bottle feeding, both which were referenced by Dr. Smith and Dr. Fairley today. And coming soon are kind of a shorter version of our responsive feeding, that's infant feeding cues, micro lessons on milk collection and storage, antenatal milk expression, which I know is a really hot topic, and everyone is facing questions and trying to develop policies around antenatal milk expression. So we're finalizing that one. And then one that will be really relevant to today's topic, which is using the Newt tool in the first 36 hours. So watch your train accounts for those additional micro lessons that are up and will be added in the next few weeks. I'll pass it back to Linda.
I just want to thank Dr. Smith and Dr. Fairley again for presenting and answering questions today. Thank you, Claire, for letting us know about some of the upcoming micro lessons. There were several resources shared in the chat, so be sure to take a look at that and just to see. On the screen is the QR code, just if you all can log into it to log your attendance. And then, as Claire said, Kimberly will be sending out an email shortly after with just this information as well. But this meeting has been recorded, so in case you want to access it, you can as well. Thank you so much.